Thank you, and I wanted to thank Kathleen and your partners for inviting me. I too have a Yukon history to some extent. When I graduated from my residency in Toronto, this is the very first place that I got to be a staff man. And I'm eternally grateful for Wayne McNichol and the family physicians and the nursing group for showing me that there was a world outside of Toronto. And certainly that played a role in my decision to practice rurally. Certainly as a clinician, when faced with a problem, it's always great to take a history. And certainly the history of obstetrics and gynecology is inexplicably linked to midwifery. As you can see, that the word obstetrics, in fact, is a Latin word that refers to midwifery. And the godfathers of modern-day obstetrics, William Smellie and William Hunter, were man midwives in the 17th century. And it's interesting to note that Smellie was violently opposed by the midwives at that time in terms of practicing obstetrics. And certainly in some places in Canada, it's been a flip side to some extent. The Chamberlains were credited with the development of the obstetrical forceps, and this at one level set us apart as obstetrical specialists. Of course, they then kept their secret hidden for 150 years, as some of you may know, unfortunately to the detriment of women who could have benefited. When we look at obstetricians across Canada, as you can see, there's a great distribution and small numbers in the territories. I think it's important as well when we look across the country that the practice patterns of obstetricians are quite varied. So in Ontario, currently upwards of 80% of deliveries are provided by specialist obstetricians. In British Columbia, it's about 50% of deliveries are provided by specialist obstetricians. And again, the portion of women who deliver rurally in the province is akin to London Health Sciences Centre or BC Women's and Children's as well, but obviously these women are distributed across the province. When we look at the demographics of who delivers babies in the province of BC, again, obstetrician numbers have been remarkably consistent. As you can see, family physicians who provide intrapartum care have diminished over the years and numbers of women delivering with midwives has increased. Again, in the province of British Columbia, we have any manner of different models of obstetrical care. From places such as Haida Gwaii, where their midwives providing the majority of obstetrical care without surgical backup, to communities like Invermere in British Columbia, where you have family physicians providing obstetrical care without surgical backup, to places like BC Women's Hospital, where the maternal fetal medicine specialists are a service unto themselves. Sorry. And certainly, the demographics of obstetricians across the country is changing. OBGYNs are generally getting older, as I guess all of us are. When one looks at obstetricians who practice rurally, the numbers in Canada are quite small. So only about 3% of obstetricians will practice rurally, only about 1% of pediatricians. And certainly in the literature, they talk about a rural obstetrician gynecology crisis, that practitioners who live and work rurally, now it's becoming increasingly hard to recruit new obstetricians. In some instances, that upwards of 50% of new graduates are planning to practice subspecialty areas of OMG that might keep them away from delivering babies. So, certainly it's become clear to me over the years that I don't have all the answers, and part of being able to see different pathways and different options is trying to go back and really understand what those things are to begin with. In medicine, they talk about the concept of personalized medicine, which mostly refers to the idea that genetics and understanding personal genomics will have huge implications to healthcare. Certainly, as a practicing clinician, to me, personalized medicine means trying to provide the best for the patients, the populations you serve, no doubt as the family physicians in the territories, the specialists in the territories, and midwives do. And so, part of the challenges I've perceived, having worked from Toronto to Prince Edward Island and all parts in between, is this idea that all three of us, midwives, family physicians, and obstetricians at one level are competing for the same uterus, that we all think we're the best to deliver a patient, and that causes some element of conflict. So again, when one talks about who is best, that means a whole bunch of things. Are we talking about best in terms of birth outcomes? Are we talking about the best in terms of cost of effectiveness? Are we talking about best in terms of what the patients want? These are all important things to consider when you're trying to establish what the right models of care. So again, the Maternity Experiences Survey, as some of the speakers have alluded today, have indicated that women appreciate having consistent providers. They appreciate not having to leave their home communities necessarily, and certainly for some, their preferences in terms of their birth experiences, depending on potentially who provided their care. The challenge of a family physician providing antepartum and intrapartum obstetrics is great. Certainly they're being pulled in many other directions, and certainly I think the advantage, though, for many rural family physicians is the idea that you can, in fact, be a full service and full spectrum provider. Again, we heard from Dr. Jensen today about the safety, and certainly over and over again, studies would suggest for large populations of patients that outcomes are good. And again, the idea that I'm the best person to deliver a baby because I can section them in a flash is balanced with the idea of, as Jeanette, the family physician who may have delivered that patient, who looks after her husband, who looks after her other children, and has a global understanding of really the crisis that family may be in, or the challenges for that family, versus the midwife, again, who may have spent many more hours with that patient in her home, who has a different perspective. And again, when one talks about costs, it's necessarily not always easy for me to appreciate that there are cost savings, because I do feel that it's important to recognize that there is obviously value to having the hospital available, to having surgical obstetrics available for many patients in the event those services are needed. Again, in terms of trying to establish what the best models of maternity care, it is complex across the country, and oftentimes things are just the way they are because someone got there first, or someone yells louder than the other in some instances. And certainly I commend you guys on trying to move forward in a data-based, ideally an evidence-based and progressive discussion. And again, it isn't necessarily all about the numbers, and certainly the value of mother stories, the value of physician stories, the value of midwife stories are invaluable. And again, as Jeanette and I had talked to, as an obstetrician, I may spend a very limited amount of time with that patient and perceive that I am an expert. That mom still has to take that baby home. That mom is spending the rest, all those other minutes of the day that she wasn't in my office, caring for her children as well. So it's important to recognize that a decision to follow or not follow my instructions isn't necessarily an off-the-cuff thing, and it took me a long time to come to that understanding that I'm not that important. My children make that clear every day. Obstetricians are still needed to provide acute surgical obstetrics, and surgical obstetrics at one level is the linchpin of rural medicine. Losing your maternity services, challenges to your maternity services can have implications for your anesthesia, can potentially have implications for the emergency department, can have a whole host of other downstream implications that aren't necessarily clear at the onset. Again, when one talks about the interactions that midwives may have with obstetricians, it can vary. So in many places, midwife, as an independent practitioner, calls me up to ask my opinion. In other models, there's a layer where the midwife may triage things through the family physicians, who then perhaps will call the obstetrician to make a care plan. Again, the challenges of being a rural obstetrician can be great. We've heard today to some extent about the midwife philosophy of care, which is different sometimes than the physician philosophy of care. Choice, from my understanding, is paramount in the midwifery model of care. And that's certainly not how I was trained as an obstetrician. I was trained to make a decision and be an expert and accept responsibility for whatever it is that you did. And those two models of care have to come together. Again, being a rural obstetrician also means you need to be a gynecologic surgeon. And so, again, one has to balance the sustainability of being able to provide intrapartum obstetrics with the idea that you still may be called upon to provide a variety of things outside of the perinatal sphere. Again, isolation can be a real challenge. Isolation for all of us, for family physicians, for midwives, for obstetricians, can make it very difficult. And again, I feel that it's really important to recognize that choice is invaluable for our patients, but also sustainability of the service is invaluable. That if you don't have a sustainable service, the patients don't have a choice, right? They got to go somewhere if there's nowhere else for them to have a baby. So again, the physician groups have created sort of models or philosophies, and that puts us at the center, which is difficult necessarily for us to balance that with the idea that maybe we're not the expert in this mother's care of her child. She might be. So, again, I was trained to be a cowboy to some extent and be able to practice and do a variety of things. And clearly that doesn't fly. And it probably has never flown that way. We've always had the nurses by our bedside. They just unfortunately haven't had the credit that they deserve in many instances. And again, the idea that we need to have a collaborative model at the end of the day, I think, makes things so much easier. So, again, I can't think of a jurisdiction in Canada where physicians necessarily welcomed midwives with open arms. I'm happy for you to tell me if there is. Certainly in Nelson, where midwives deliver perhaps a third of our babies, the physician group had to be dragged kicking and screaming back to the labor room. Eventually, they realized that we're all dedicated for the same purpose, and now I think we have a really great service. But the challenge is there is that transition period, and part of the challenge in the isolated remote communities is women don't necessarily have a choice to vote with their feet. If you're in Surrey and you as a mother don't like the relationships the midwives or nurses have, potentially you can go somewhere else. You can go to Royal Columbian, or you can maybe potentially seek out a different care provider. And that may be very difficult in an isolated remote community. Again, I find that some of the challenges to collaboration are managing patient expectations, which may be very foreign to how I was trained. Again, the relationships that obstetrician gynecologists have with the family physicians are very tight because we all went to school together, we all trained together. Family physicians played an integral part in our education as specialists as well, and that isn't necessarily the same in the midwifery sphere. And again, the idea that I was taught that I need to be the expert as necessarily about supporting patients' choices are two very different things. And it's really important to try and find a way that you can link those together. For some, it is about loss of income. It may be loss but it isn't just about income. It is about why it is they potentially became a rural physician in the first place, because they wanted to look after patients in challenging environments. Obviously, there are advantages to OBGYN and midwifery and family physician collaboration. Again, in Nelson, we have any manner of choices from a midwife who will work as a solo midwife to family physicians who will work as solo midwives. As Jeanette mentioned, you have a collaborative clinic as well that women can access. And our job as OBGYNs is mostly to provide consultative care only. Again, as Dr. Jansen indicated, the opportunities for rural health research is vast. And I would encourage you at the onset to get the numbers and follow them forward. Again, there may be opportunities. So, certainly our maternity system works for midwives to deliver babies because there is a family physician, mostly. We have a single pediatrician who is there to help them out with respect to the baby. And that is a challenge at one level if you remove the family physicians from the equation of providing primary care, as if there is a child that needs a higher level of care, who else may be called upon to assist them. Again, it took me a long time to realize if somebody doesn't like what you think or opposes you, it's not because they're stupid or don't care. It's because they're passionate in a different way, and it's taken me a while to understand that you need to figure out why don't they like what I'm trying to say. It's obvious that what I'm saying is right. This doesn't apply to my children. This is meant to be facetious. As Donald Trump, unfortunately, may be the next president of the United States, some might say. But again, I think that a discussion that involves thinking and planning is so important, that all the players who potentially may be affected, patient populations, EMT services, midwives, family physicians, obstetricians, anesthesia, administrators, there has to be a really, really comprehensive effort, I think. That isn't the way it oftentimes is played out. It's oftentimes played out, the physician said, no way, Jose. The administrator said, too bad, this is the way it's going to be, play nice. But again, my concern in a smaller remote communities is that transition to learning to respect each other, learning that each other are not complete fools, may result in some attrition. And it's very difficult in a small community necessarily to support that. Thank you.